Yes, it's happening and it's worked, and it's 7 o'clock on a Tuesday night, which means I've got some questions to answer, which I will happily do. So if you want to ask me a question, you can, but if you don't, then don't. Simple as that. So what we got? So we got question number one. Question number one says, do we do fat dissolving injections to remove a lipoma? Simple answer, no. Actually, can you do fat dissolving injections to remove a lipoma? Well, I'm not aware that you can do it, so that would kind of answer the question that it's a no from me. But I mean, the problem with fat dissolving injections is quite non-specific, and so you don't know what sort of area you're doing. So I would imagine it would be quite hard to localize it, but it is me imagining that because I don't do it. So it's probably best I don't comment on it too much. You're probably better talking to someone who does do it, who might be able to give a more comprehensive response. So yeah, I don't do it. So and I'm not even. I'll be interested to hear if people do it. Does anyone do it out there? Anyone do fat dissolving injections to remove a lipoma? No, I do surgery to remove lipomas, which means making a sort of cut in the skin and removing it that way. And yeah, that's the way I remove lipomas. Why do you offer lower blepharoplasty to be performed under general anaesthetic? Yeah, so upper blepharoplasty. So blepharoplasty is kind of like an eyelid lift, I suppose. It's a removal of excess skin on your eyelid, tightening the skin, I suppose, upper eyelid and lower eyelid. Upper eyelid is literally just taking an ellipse of skin from the upper eyelid, and is something that's quite commonly done under a local anaesthetic. And I would say it's kind of quite standard to do it under a local anaesthetic. Lower blepharoplasty is a little bit more of an involved procedure. Often things are done with the fat pad. I don't do either of these, by the way. So I don't do either of these ops. But anyway, you've asked. I'll answer the question. So best to talk to your surgeon. But we do it. We have surgeons at the clinic who do it. So yeah, probably should have got them on to answer this. But anyway, lower blepharoplasty, often more work is done, often with the fat pad here. Often it's extended, and it's sometimes sort of called a mid-facelift because it kind of tightens the whole skin. Obviously, no skin to be tightened here, but obviously, it's more of an extensive procedure, basically, simply put. So the dissection is more extensive, often deeper, because the tissues are mobilized around the cheek and the lower eyelid, and so it tends not to be done under local anaesthetic, so it would tend to require either a general anaesthetic or local anaesthetic with sedation. But it would kind of need more of a hospital setting than what we have at the clinic. We are local anaesthetic at the clinic, so it's a bigger procedure, so a lower blepharoplasty, but it's not performed quite as commonly, I don't think, as a upper blepharoplasty, so that's good. Well, maybe, that's what it is. Can I have areola reduction and then breast implants at a later date? Yeah, absolutely no problem at all. But given you're asking the question, in which case you're considering both procedures, an areola reduction and a breast implants, sometimes people ask whether breast implants cause the areola to stretch at all. And I don't think it's significant, but I do think there is sometimes a little bit of a stretch on the areola, obviously because there's a bit of tension put onto the breast and the breast skin, and the areola is part of the breast skin. So there might be a degree of areola stretch, if you like, if you're having breast implants put in. So if you are aware of the size of your areola and you are worried about the size of your areola and want your areola to be smaller, if everything else is equal, and everything else might not be equal, there might be a reason you want it done in this order. I would suggest it might be better to do it in the order of the breast implants first, just to see if they cause any stretch to your areolae, and then areola reduction once it's a sort of stable platform. As a general rule with surgery, we try and do surgery on people on a stable platform when things aren't changing, when things aren't moving. And so if you are going to go and put an implant in, that might change the shape of your areola. So it'd probably be better not to do the areola reduction before putting the implant in. From a surgical point of view, it'd be better to put the implants in, see how you go in terms of your areola. And if you're unhappy with your areola, you could have an areola reduction at a later date. But if there's a particular reason you want to have the areola reduction first, yes, you can, because I don't think the implants will significantly, at least I've never seen anyone really who it's kind of significantly stretched the areola. But I don't use particularly big implants, so maybe if you did use particularly big implants, it might stretch them. So maybe that's just something to think about anyway, something to consider. Now into the mix. Can I breastfeed after having inverted nipple correction? So inverted nipples are usually due to the milk ducts being shortened, and there are different ways you can treat them. So you can use a suction cup device such as a nipplet, which is a little thing like a thimble that goes over there and negative pressure and can kind of try and stretch out the ducts. So that's usually the first port of call. And so if that might correct the inverted nipple and you would still be able to breastfeed. I usually say to people, it kind of depends on whether you can breastfeed. Some people can't breastfeed, so you might not be able to breastfeed anyway. But if you want to be able to breastfeed and you try the nipplet and it doesn't work, then there are ways you can do the surgically evert the nipple, kind of pull it out. And basically there's kind of two ways. One is to cut the ducts, which therefore means you will not be able to breastfeed. If you say I absolutely have to maximize my chance of breastfeeding, there is a way where you can kind of try and tease out the ducts and put some tissue underneath to bolster it up. But I have to be honest, personally, I haven't found that to be very successful. And if the ducts are shortened enough to require surgical correction, I haven't found it to be very successful to use the technique where you leave the ducts intact. And so personally, I kind of wouldn't do it. I would only do it if I could cut the ducts. If you wanted to see if you could breastfeed, I would say, look, you probably best finish any family before having an inverted nipple correction. And then when you do have it surgically corrected, as I say, the suction cup might do the trick. But if you're having it surgically corrected, in my hands, I would always cut the ducts because I've had mediocre, shall we say, results when I don't cut the ducts. And so I would say, look, it's probably better off not having anything really and just breastfeeding and doing whatever you can do. And then once you're all finished with that, then you can consider the inverted nipple correction. But that's just me. So there is out there a technique where you can do it by keeping the ducts. So you might find someone who'll do that for you. So that might be an option if you want to be able to maximize your chance of breastfeeding. But as I say, you might go through all this and then find you can't breastfeed anyway. But if you want to, give it the best chance, then probably I wouldn't do my sort of surgery, because you absolutely won't be able to breastfeed if you divide the ducts. And the reason it's not very good when you don't divide the ducts is because they're so tight, it just pulls down again. And even when you divide the ducts, there's a risk it can pull down again. So it's just, to maximize your chances of a result that's not going to recur. And so, as I say, even with the duct cutting technique, there's a chance it can pull down again. So it's very hard to do. Certainly a deeply tethered inverted nipple without cutting the ducts, in my experience. Do you offer liquid rhinoplasty? No, I don't do any kind of fillers. I don't do rhinoplasty. So I don't do liquid and I don't do rhinoplasty. So I failed on both counts on that one. So yeah, the rhinoplasty obviously is changing the shape of the nose. Liquid is using fillers basically to do things to the nose. And so I don't do fillers and I don't do rhinoplasty. So I don't do liquid rhinoplasty. That's a negative. That's a double negative in many ways. So yeah, sorry about that. I can't even comment on it. I don't know if it's a good thing or what. I don't know if people who do rhinoplasty think it's good, or I suppose putting filler in the nose is kind of possible. Hold on a minute. Something's come up. All right, I've got to wear glasses. All right, don't judge. Any advice in the order of which skin removal surgery everywhere needs attention? Not sure where to start. Well, personal decision, absolutely. Yeah, definitely whichever is the worst. But in my experience, usually tummy and breast are the places where people usually start, simply because those are the areas where the scars are hidden. Basically, when someone has massive weight loss, I guess it's tummy, breast, thighs, arms, maybe face, kind of facelift and things. But in terms of the body, those are the areas. And the big difference between the tummy and the breast compared to the arms and the thighs is the scars are quite well hidden when you do the tummy and the breast. So the breast, whether that be a reduction or a lift with implants or whatever it may be, the scarring is kind of hidden from the nipple down, so it's hidden in a bra. So that is good. And the tummy, the scar is hidden in your underwear, although there is a scar around your belly button, but still it's pretty good from a cosmetic point of view. So those are far more common in compared to arms and thighs. Arms and thighs, the scar, well, there's different ways to do it, but the most effective way to do it is to put a big long scar down the inner aspect of the arm. Similarly, big long scar down the inner aspect of the thigh. And so those can be quite obvious if you're wearing short sleeves or short trousers. So that can be an issue. If you say, oh, I can't stand showing my arms, I can't stand showing my legs, you might still not be able to stand showing those areas if you have those scars. So usually it's breast and tummy. Between the two, it really is a personal preference which one you have first. That you can have them both together. Some people will combine them, and it is kind of personal. I guess the tummy probably recovering a little bit more than the breast, unless you have a breast lift with implants. Well, even with the breast lift with implants, I suppose the tummy is kind of, I guess, a bit more of a big deal, a bit more invasive than the tummy is a bit more invasive than the breast. I don't know if that helps with the order. You do the more invasive one first, but yeah, I haven't got any strong view about between those two, but just usually speaking, those two are the ones that people kind of get the most benefit from, because they get obviously a significant improvement in the contour without too much in terms of visible scarring, whereas the arms and the thighs are much less popular because of the potential for more obvious scarring. Do you do chin lipo to get rid of double chin? Thank you. Ali B, are you being personal there? Or is that a serious question? I mean, you should see on TikTok. Yeah, okay, maybe I could do with a bit, all right? I'm going to take that question in good faith, Ali B, and not trying to take it personally. No, I don't do chin lipo anyway. So I don't do faces. I mean, I do, to be honest, more of this work that I'm doing now is kind of moles, cysts, lumps, bumps. So obviously, well, maybe not obviously, but a lot of those are on the face. So I do a lot of that sort of facial surgery. I do earlobe surgery when earrings are pulled through and what have you. But in terms of facial aesthetic surgery, I don't do facelifts, blepharoplasty, rhinoplasty, chin lipo, stuff like that. I don't do Botox fillers, so I don't do facial aesthetics. My main kind of subspecialty interest was breast. So I was I am a plastic surgeon still with a special interest in breast, but I'm focusing more on the minor ops at the moment, the low anaesthetic moles and cysts. But in terms of my sort of training, I suppose it is in breast. I did do sort of facial cancer reconstruction in my training, and was looking at potentially doing a facial consultant job, facial head and neck cancer reconstruction job, but I ended up going into the breast reconstruction world. That was where my consultant job was, so that's where I moved on to do most of my private work has been breast, because that was what my NHS work was. So anyway, the point is I don't do aesthetic faces. Serious question. Okay, LAB. Yeah, good. You weren't being personal. Good. Yeah. It's okay. I don't. Yeah. So don't do chin lipo. Sorry. No, that'll be a facial plastic surgeon or a plastic surgeon who. In fact, most plastic surgeons do a bit of face, to be honest. So yeah, that'd be another plastic surgeon, I guess. But not to me. Sorry about that. I can't be more help, but thanks for getting involved. Bit of involvement there. Thank you. When can I return to my office job after having a 10 centimeter lipoma removed from my back? Well, 10 centimeter. It's a big boy. That's a big boy. I mean, you can probably go straight back. I'd have the day off, but it'll be a bit sore. I mean, the thing about lipomas, they're underneath the skin, and so you don't actually have to take any skin out. So the skin isn't closed under a huge amount of tension. So you don't have like a big sort of tight wound, if you like. You do have a space where the lipoma was, and that space can fill up with fluid, and it can swell, and it can be uncomfortable, and it might swell up, and you can have problems, and there's all sorts of issues. But it's not, in terms of activities, I probably wouldn't go too crazy in terms of getting hot and sweaty, because you have a waterproof dressing on there, so you don't want to get too hot and sweaty for the first week. But presumably your office job, you're not getting hot and sweaty. So, I mean, on paper, you could go back the next day. Now, if you say that it's going to be heavy lifting and it's going to make it swell and be uncomfortable, and they're not really going to allow you to take it easy a bit, then a week off. But if they're not, if they're going to be sympathetic and acknowledge that you've had surgery, then you'll be able to sit in a chair. You'll be able to type and talk on the phone. I don't know whatever your job involves, but you should be able to go back on paper next day. I mean, obviously you might get a problem, you might get a wound healing problem or an issue or something like that. It might, so you might want to take a few days off if you want. Crumbs, was that as unhelpful as it sounded? So yeah, either next day, a few days off, or a week. Between next day and a week is the range. Okay. But yeah, next day is kind of probably what I'm thinking, really, unless you really feel that you're quite active in your job. So yeah, good. Right. Okay. Sorry. Okay. That's it. I've got no more. I've got no more questions. So if you haven't got any questions, I'll put you in for then. Oh, that's right. Okay. So WhatsApp message. Right. Good. Thank you. Good. So if you, yeah, that's it. I don't know what you're still here for. That's it. I'm done. Well, if you have you got a question, I can answer it. But if you haven't, I'm done. More ways than one. So I will bid you good night. I will see you next week, I think. almost certainly. Can't imagine any reason not to be here next week. God willing, I'm going to have some questions. Well done, Instagram. You get the award for asking questions, because I think I'm right in saying we had 2. Did we? The chin liposuction or something else? Can't remember what it was now, but it was, oh yeah, the order of things. So yeah, 2 questions, which is good. But we will put any questions we get during the week on a list, and I'll do them next week. But if you have any questions,